Is from Lung, Saskatchewan, Jamie Peters. She is also a registered nurse and CRE. I would like to thank Lung, Saskatchewan for providing the support needed to host this event. We've been working together for a number of years now and had quite a bit of success reaching people throughout the province. And so it's been great. I will start with a quick land acknowledgement. I'm hosting this event from Treaty 6 territory. The Saskatchewan Health Authority and Lung Saskatchewan acknowledge the many Indigenous peoples whose footsteps have marked these lands for generations, and we reaffirm our relationship with one another. We know that many of you are participating on land other than Treaty 6, and we would encourage you to find out a little bit more about the land that you live, work, and play on. This talk will be recorded. However, Lung Saskatchewan will work to de-identify the participants, and the question period at the end will not be included in the recording on the website. Our presenter today is Dr. Veronica Marcoux. Dr. Marcoux is a respirologist with specialty training in interstitial lung diseases and pulmonary fibrosis. She completed her internal medicine and respirology training at the University of Saskatchewan and an ILD fellowship at the University of Calgary. Currently, she co-leads the Saskatchewan ILD Clinic, which is one of the participating sites in the Canadian Registry for Pulmonary Fibrosis, which is a database being used to help further research and gain a better understanding of these diseases. So today, Dr. Marcoux will be discussing an upcoming therapy option for pulmonary fibrosis. And so without further ado, I will hand it over to her.
Great. Okay, thanks, Shane. Like we've heard before that people want to hear about, what's new in regards to treatments. I figured we would talk about treprostinil because this is probably going to be hopefully our next up and coming drug that is going to hit the market maybe after the other one that Dr. Locke talked about last time, which is called nerandomilast. I figured I'd just get ahead of it and maybe we can just talk a little bit about, where things are at with this, where the studies are at, and then, where is it approved right now for use. So I will take it all the way, step all the way back though. We'll kind of review super quickly basic lung anatomy and then very basically like what is pulmonary fibrosis and then what is pulmonary hypertension because that's an important aspect to this because treprostinil was originally a drug used in a condition called pulmonary arterial hypertension. So that's actually where this drug comes from. And then we're going to talk about a few of those big trials that have come out in relation to this. So just super, basic, if we just remember our basic kind of airway anatomy and lung anatomy is, we've got our upper airway system, which includes your sinuses and the oral airway, which comes down to your voice box or larynx. This big airway that comes down into the chest is called the trachea, and then it splits to the two lungs, the right and left side. And so as that big airway comes down and splits, it divides over and over and over. And so every time the airways split and divide, they get smaller and smaller. Eventually, we get all the way out to the final parts where it stops dividing. And then we get these areas called alveoli, or which are like the air sacs. And these are what's important because this is where actual oxygen gets into your blood. And then this is also where the bad gas gets out, or carbon dioxide. So this is where the actual action happens for the lungs themselves. And so you can imagine it's a pretty complex structure because I'm really just showing you the airways, but embedded in all of this also is a lot of supporting connective tissue which holds all this stuff up. And in lots of blood vessels also travel all along all of these structures. And that's kind of the important part of this talk today. And then something called the lymphatics, which is kind of like the drainage cleanup system for the lungs. And so, in order to just kind of get it, I know this is a bit of a complicated picture, but I just wanted to focus on, these pulmonary vessels because this is the important part of where treprostinil actually acts. So this is the right lung on the side. This is the left lung. So the heart sits in the middle of the chest for the most part. And then it has these really large veins that come and drain blood from the lower part of your body, the upper part, and that blood drains into this, what we call the right side of the heart. And the reason we call that is because it sort of sits on the right side and it pushes the blood into the lungs. Whereas on the other side, the left side, that's where the blood comes back from the lungs and then it pushes the blood out to the aorta and out to your body. So when the blood comes in through this top chamber, which we call the right atrium, it passes through a little valve here, and then this is the right ventricle. And so the right ventricle pushes this blood up into this really large artery that we call the pulmonary artery. And so this is kind of the focus of where these medications had first come into play because this disease called pulmonary arterial hypertension essentially means high blood pressure in this artery or high blood pressure in the lungs, which is different than what we normally think of as high blood pressure or hypertension, which comes from this side of the heart, the left side, where we measure it in our arm. So if you really just want to get like a grand sense of what all this means, and like I know this is quite complicated, but if we were to cut a piece of lung out and actually look at it under the microscope, you can see it's a pretty complex layer of all of these little levels that I was just talking about, which don't look as nice as they do on the pictures and diagrams. But you can see it's quite a fragile structure, and yet somehow it manages to keep its strength and keep its ability to get oxygen in, oxygen out. So if you remember back to this diagram here, what I'm actually showing you is this in actual real histology, because this is what we look at when we look under the microscope. So this is that big airway coming down in this really small far out area of the lung. And all these little tiny lines, this is that supporting tissue that makes up the actual gas exchange. These are the alveoli here. And so the important thing about this is that, you've got these tiny little dots, these things here, these pink areas, this here. Those are those blood vessels. And the blood vessels will actually play a pretty important role here because they're bringing that blood in through the lung. The oxygen gets onto those vessels and then flows out. And so in fibrosis, as this tissue becomes more thick and destroyed by scar tissue, that also destroys all of these blood vessels. And then when you destroy the blood vessels, you're going to get higher and higher pressures, which is that pulmonary hypertension, because suddenly you're having blood getting pushed into less space, tighter blood vessels. So just to remind us, interstitial lung disease, you'll hear us say that, and then you'll also hear us pulmonary fibrosis. These two things mean the same thing. We kind of use them interchangeably. And this is not a diagnosis, it's an umbrella term for over 200 actual specific diseases, some of which actually aren't fibrotic. So that's why sometimes it can be a little misleading. The fibrotic lung diseases definitely do, though, have that scar tissue or fibrosis. But some diseases are solely inflammatory, and so they don't have scarring or fibrosis. And the interstitium, that word that comes up in interstitial lung disease, what that word is, it's that support tissue that I was just talking about. It's the actual thing that holds everything up in the lung, like the connecting tissue, the little cells that hold everything up, your blood vessels that run in between. And the whole point of it is it maintains structure, it maintains fluid in the right places and not in the wrong places. It's where blood flows and gets oxygen in and out. And then also there's an element of some repair and remodeling. But unfortunately, sometimes that doesn't get repaired, and that's where the fibrosis comes into play. And this is just a really simplified picture, kind of demonstrating again that function of this being an alveolus and this being a blood vessel coming through. So you get your bad gas out, you breathe it out, and then the oxygen moves into the blood vessel. It moves back towards your heart. So I'm not going to go over this, but this is just to show you that, there's a lot of different diagnoses that fall under this big category of interstitial lung disease or pulmonary fibrosis. Some of them can be idiopathic, which just means that they don't have known causes. Some of them can be from autoimmune conditions or exposures. And then lots of other things such as vasculitis, a condition called sarcoid. I could go on and on. But basically what they all can lead to are symptoms of shortness of breath, cough, chest tightness, wheeze, poor exercise tolerance, and feeling fatigue. So that's why it's important to see if we can get better treatments. Because really, we're really limited to antifibrotics right now, which are nintedanib and pirfenidone. And then if we are dealing with inflammatory conditions, we kind of use other drugs like mycophenolate. So then, what about the vasculature though? Because we really haven't been focusing on that in the fibrotic lung disease world. And so, what about these blood vessels? Because we know that they're getting destroyed. We know that they're leading to some issues with developing high blood pressures on the right side of the heart because of the fibrotic involvement of the lung. So that's where they hypothesized that maybe the drugs that we use classically in pulmonary arterial hypertension, which is basically are used to dilate the blood vessels of the heart and the lungs, to reduce that pressure as much as possible. So some of the studies that used these drugs in idiopathic pulmonary fibrosis, which is a specific diagnosis, were actually having to be stopped early because when they were giving people these drugs, they were actually causing harm. And so those were drugs that were being given either, through an infusion or under the skin, which we call subcutaneously. However, there was one drug called sildenafil, which, actually was showing some potential benefits in idiopathic pulmonary fibrosis. And so a lot of, research had gone into looking at that drug, which is a pill, in people who had both fibrosis and documented high blood pressure in the lungs or pulmonary hypertension. And how do we document that? Well, we do an echocardiogram, and we also do an invasive test called an angiogram, and a right heart cath, where they measure with a catheter placed right in here into this pulmonary artery. They measure the pressures, and if those are high, then they were saying, well, these drugs might actually be a benefit. And then this other drug called treprostinil, which is either infusion or can be given under the skin in pulmonary arterial hypertension. They have actually found a way to make it inhaled. So you can actually inhale it either as a nebulized or a powder formulation. And so this drug is called the prostacyclin, which basically just what it does is it dilates the blood vessels in the lungs, but can also dilate the blood vessels, in the rest of the body too. And it also has a bit of an effect on our platelets, which are little cells that help us clot our blood when we cut ourselves and bleed. So in that way, it can also have an ability to increase bleeding risk. But so that's kind of the way that drug works in pulmonary hypertension. So they thought, what if we give this drug as an inhaled medication to people who have in any kind of interstitial lung disease and known pulmonary hypertension. So they would have had to have that invasive heart test to show high blood pressures in the lung. This is actually like the nebulized device that they use in those trials. It's a pretty complicated looking device, but probably actually quite easy to use because it comes with little cartridges that you just load into the device. And then you take your inhalations off of this. And so this trial was actually published quite a number of years ago now. It was back in 2021. They called it the INCREASE trial, where anyone with ILD, so it didn't necessarily actually have to be a full scarring lung disease. Some of them were also inflammatory. They were randomized in this study to either receive the drug or they were receiving placebo. And this drug is given 4 times a day. So you start low, and then, as they tolerate the medication, as long as they're not having side effects, they titrate it up to 12 breaths off this device 4 times a day. And at the end of the study, they found that there was actually an improvement in the forced vital capacity. That's what FVC stands for. If you guys remember when you do your breathing tests, or when you've seen these tests done, is where the technician has you, breathing regularly, and then they say take a fast breath in, and then you blast it out as hard as you can, and you squeeze until you can't squeeze anymore. What we're measuring is how much air you can take in from top to bottom. So that's the forced vital capacity. It's measured in milliliters, and then we convert it into percent predicted based on people's height and weight. So that's what it just means by percent predicted here. So they saw that there was an improvement in the percents predicted, and they also found that at the end of the study, people who were on treatment were less likely to have some worsening in their disease. And anytime a trial is shown to have a positive endpoint, they do something called an extension trial, where they actually open it up, and they'll continue people who were on treatment. And then the people who actually were on placebo are given the option to go on treatment. And so they extend everybody who is interested on drug. And so even in the extension trial, they found sustained improvement in the people who were already on it. And then the people who switched off placebo also had improvement in their forced vital capacity. So that's kind of new because normally in fibrotic diseases, we haven't had many trials that have actually had an improvement. All it does is slow down progression so far. So because of this study, this drug was approved for patients who have ILD and pulmonary hypertension in the US only. This was not approved in Canada. It was just approved in the US. and they had to have documented pulmonary hypertension. And the biggest side effects associated with this, as you can imagine, are related to inhaling something. Because anytime we inhale things, there is the risk of having irritation from that inhalant. So the throat irritation and having discomfort in the throat in the people, and you see in this column here, these are the people who were on the known medication. These are the ones on placebo. Most commonly, it was throat irritation and discomfort from the inhaled product. And diarrhea, 13 versus 12%, is actually pretty similar, which is finally a nice thing to hear because usually in all of our drugs that we're using in fibrosis, so far they cause diarrhea. So it's really not too much of an increase there, which is nice. Some reported dizziness. The shortness of breath is similar, a little bit more headache, and maybe a little bit more cough, probably from inhaling. So the other things that they noticed was that when they looked at the diagnoses of the people in this trial, the ones who had a diagnosis of idiopathic pulmonary fibrosis or actually had fibrotic lung disease for real, like not just the inflammatory components, those people had an even higher improvement in their FVC in general. And then just getting a bit more technical, there's some thoughts now that because this is the first time we've seen some improvement actually in lung function, is they started to dig a little bit more into like how the treprostinil might have had that effect, because we really just thought it was supposed to dilate blood vessels. And then they started looking in mouse models where they, unfortunately, these poor mice are given fibrosis, but they can study then the effects of drugs in these cases. And they were seeing that it actually had some anti-scarring or anti-fibrotic mechanisms as well. So this really got them thinking, and they decided then to create these trials called the TETON trials. And now it was no longer actually just restricted to pulmonary hypertension, because now we're thinking, oh, this drug actually has an effect on fibrosis. Let's open it up to everyone, not just the people who have pulmonary hypertension. So, kind of in the general theme of direction we've seen trials go, there's a trial designed to look at this in IPF alone, because IPF is a specific disease that we know is limited just to the lung. It doesn't affect other organs. It's unfortunately a known progressive condition in some cases, right? And then also, I'll talk about it after, but the other subset of this trial is going to be looking at people who don't have IPF but have progressive fibrotic lung disease. So the TETON trials, the TETON 1 and 2, these are the first ones that are going to be published, probably in the coming 6 months, hopefully. But they've released kind of their early results. So TETON 1 and 2, the reason sometimes that they create two trials is because they want to make sure that they have strong evidence. And so they'll run it essentially a mirror image of the trials, like they're all the same. But in this case, TETON 1 was run just in North America, so USA and Canada. And then TETON 2 is outside of Canada and the US. In case you're wondering, those are all the countries. That study actually, as you can imagine, because it has more sites, it achieved its enrollment faster than the ones in North America. So they actually completed their enrollment in July 2024. And so that allowed them to release that data early, okay? And the nice thing is that they didn't restrict the medication to people who were not already on stable anti-fibrotic treatment, because we know that those are proven good treatments. It wouldn't be ethical to withhold that medication from people. The other restricting component, though, is like in order to get in the trial, you had to have lung function with a forced vital capacity of 45 or higher. So what they looked at, though, once people entered into the trial, they were either put on placebo or drug. It's blinded, which means that you're not aware of which drug you're on, and neither is the investigators at each site. And then what they do is they measure the lung function over time. And then at 52 weeks, that's kind of the end point. The one thing about it is like when trials are being run, though, it's 52 weeks from the last person that gets enrolled. Okay. So that's why sometimes the trial just continues on, because it does take time to enroll people. The other things that they looked at, though, which we call secondary endpoints, it just means like the primary endpoint, the big thing that's of most interest or concern is how well that FVC does over that 52 weeks. But the secondary endpoints that they also look at are, how much time does it take for someone to lose more lung function, which is time to worsening, or have something called an exacerbation, which is a sudden flare, what was the survival at week 52, and then how much percent did the FVC change. And then they also administer a symptom questionnaire, which looks at quality of life and symptoms. It's called the K-BUILD in case anyone's interested. Teton 1, which is the North American one, it completed its enrollment in January 2025. So, in case anyone's wondering, I don't know how they come up with the names for these trials, but usually they piece it together from words in the actual long title, where they'll just randomly take letters to make a nice word that they enjoy. The Tetons, in case anyone's wondering, is a mountain range in the Wyoming state. So what they actually had over 500 patients for Teton 2. So this is the data from Teton 2 that they came out with in September 2025. Which is a great number because it used to be very difficult to enroll these kind of numbers in these trials. Over 52 weeks, the drug was shown to be superior, meaning it performed better than no drug or placebo. And there was a difference in the absolute FVC by almost 100 mils, which doesn't sound like a lot, but it actually is quite a bit, right? When the grand scheme of things, when we're looking at lung function changes over time. And it was regardless of whether or not they were on nintedanib or pirfenidone or nothing, regardless of whether or not they smoked, which sometimes can affect, the dynamics of the lung, and even if they were on oxygen or not. They also had some trends towards significance, but it didn't meet statistical significance for the time to first exacerbation and overall survival. Just remember though that this is just the first part of the trial because they're going to combine it ultimately with the Teton 1 data as well. And then the safety profile was very similar to what I had just shown you before from that other study. So nothing kind of new had come up as far as the safety signal goes. The other nice parts, though, is that like this, we never see this. We actually saw some improvement apparently in the symptom and quality of life questionnaire, which is nice. There was potentially some significant improvements as well in the DLCO and time to first worsening. So it's coming as a positive, I think, finding from this drug. So the Teton 1 still obviously needs to have like finalization of its data, and then they're going to start analyzing that as well. And typically what they'll do in these concurrently run trials is they're going to combine all of that data together as well. So we're hoping that it's going to come out as like a publication by like May 2026. So the other study that I was talking about, though, that's running kind of concurrently, but is still actually enrolling right now, is Teton PPF. So PPF stands for progressive pulmonary fibrosis. So these are, say, people who, have scleroderma and pulmonary fibrosis and are progressing despite being on like standard treatments. And that would be things like, mycophenolate or the addition of nintedanib. And so that they have to show some kind of progression, but this study is limited to people who don't have idiopathic pulmonary fibrosis. And the studies, goals and things that they're going to evaluate are the exact same as the last one. So what is the change in the lung function, which is FVC, at week 52? And then, of course, the quality of life questionnaires and other secondary endpoints. And this trial it's still going. And I was just going to show this to people in case they're interested. The way that trials are run is we identify people that are interested in the study and we go through something called a screening period where we just like evaluate, is this person, do they fit all of the yes and no components of being involved in the trial? So inclusion and exclusion criteria, that's the screening period. And then we always do a day one visit where we meet and fill out all the initial paperwork. And then people come for their subsequent visits 4, 8, 16, 28, and 40. And then you go all the way out until the end of the study visit. And then usually if it's a positive trial, that actually will roll over, like I said, into an open label where you're on drug trial, where we continue to assess your endpoints. And the reason I'm bringing this up just is because this trial is still going, and we are having like Canadian sites entered into this, and our site is going to be hopefully activated probably within the next 2 months. So our site is going to be participating in this study. So everything I presented here, this is published data already, like the stuff is available already online. And what I'll just briefly talk about here is like what are these devices? So In the US, the drug is called Tyvaso. That's the trade name. Okay. So treprostinil is the generic name. There's two forms of it. There's this nebulized one, which is this device right here, where you put your little cartridge in and then it runs and nebulizes it into like a mist. And then there's also a dry powder inhalation as well. It's this device here. This opens up almost like a stapler, and you put a cartridge in there, and then the cap comes off, and then you inhale off of that instead. And so it's just two different options to be able to take the medication. So Tyvaso, it comes, like I said, either as nebulized, which is an ultrasonic kind of little device that nebulizes it for people, or that dry powder. The nice thing about the nebulized medication is that can actually be stored at room temperature, so you don't have to have special equipment to store it. The way it's dosed is just like in the trial, like I mentioned, it's dosed 4 times a day, waking hours, so you don't have to wake up in the middle of the night to do it, but it's like kind of morning, breakfast, lunch, supper, bedtime, probably. And it takes about 2 to 3 minutes for the full kind of session of breaths. And the target dose is to do 4 breaths of that medication 4 times a day. But not everybody can tolerate it, right? So you kind of work your way up on it until a person can tolerate the full dose or whatever it is they can manage. And then in case people are wondering, like, well, what are, the other warnings? What's the precautions? What are things we need to worry about with this medication? Just like any inhaled medication, probably that has like a nebulized component to it, there is always a risk of something called bronchospasm, which just means like the components of the inhaled, um, substance. It can irritate the airways, and the airway suddenly will react, and it will almost spasm and then contract, and then the airway just gets smaller. And so we call that bronchospasm. And particularly if people have asthma or COPD, their airways may be more reactive, and so there's that potential risk associated with it. In the study, obviously, the first dose is always given, monitored, and watched. And then, of course, like anything that can affect platelet function, because platelets are required for blood clotting, there is a potential risk of increasing risk of bleeding with this medication. Thankfully, because it's not going too systemic, that risk is not as high as if it is being given like through the intravenous. And then if somebody already has a like if they're already, somebody who has quite low blood pressure, because this medication dilates the blood vessels, if somebody has low blood pressure, it can make blood pressure even lower potentially and cause dizziness and symptoms related to that. The doctor should always be aware of like what drugs do you take if they're prescribing it, and be aware of what potential drug interactions are, and then work with somebody to either mitigate that risk or reduce it or not use it at all. And then in the post-approval period, so like this is in people who are using this drug. Sometimes if there's a bad reaction to something, we always report that to the manufacturer. And so one other adverse reaction that was reported in that instance is called angioedema, where people can get swelling. And it's almost like an allergic reaction in a sense. But we don't really know what the actual percent of that is. It's probably quite rare. So cough, throat irritation, those are probably going to be the biggest side effects associated with that, and probably headache. But this was from a systemic trial. Sorry, for a pulmonary hypertension trial, these side effects. So probably the ones I showed you before, again, throat irritation. The other nice thing is that, this drug, even though it is cleared by the liver, there is some potential that you can use it in people who don't have normal liver function. And there's no dose adjustments required at all in people who have kidney dysfunction, which is also nice because those are limiting things in the antifibrotic drugs. In case anyone's like worried about carcinogenicity, or like can it cause cancer? Probably very much no. They did a study where they exposed rats, poor rats, but exposed rats to the drug at extremely high levels, and there was no risk of developing cancer that they found in those studies. So the bad news is this is not available in Canada yet. It's available in the US only for people who have ILD and documented high blood pressure in the lungs already, or pulmonary hypertension. But the hope is that once they can complete and fully publish those first TETON trials in IPF, and I suspect that they're going to wait for the TETON PPF study to also complete, And then, as long as those are all positive, I suspect that they will proceed with getting approval in Canada, which is going to still be a ways away. But just in case people are reading, because like they are putting out notifications and like it is something I think to be positive about. It's there. It's just not available yet.